Dissection of an opacified intraocular lens keeping the posterior capsular rim intact. No financial interests. She is a 64-year-old lady who has undergone cataract operation 7 years ago without any other major history. Examination: both eyes revealed pseudophakia. Right eye revealed opacified IOL with superior stromal atrophy of the iris. Pupillary dilatation was 3/4. B scan was done which revealed a retinal schisis. The left eye, which is the other eye, was within normal limits. Vision recorded in this eye, the operated eye, was perception of light and accurate projection of light. The optical biometry was done in pseudophakic mode. Here we can see the superior stromal atrophy of iris, which indicates some kind of tissue handling during the previous surgery. The optic is visualized, however, the haptics are not clearly visualized preoperatively. In view of all these findings, a decision of small incision scleral tunnel is made, keeping in mind the necessity to implant a rigid PMMA intraocular lens. The dissection is completed and anterior chamber is entered. On entering the anterior chamber, it was seen that the capsule had fibrosed almost 360 degrees. Various methods of dissection are tried. Here we can see that injection of HPMC viscoelastic is being done in order to dissect the capsule so that we can separate the anterior rim. Viscoelastic is injected all around . In addition to dissection, manual dissection is being done so as to release the adhesions. The instrument is passed in between the anterior capsule and the IOL, carefully lifting the edges of the anterior capsule. During all these steps, we have to be very gentle and careful not to damage the zonules or rupture the posterior capsule. After careful and gentle dissection, the haptic optic junction was gently dialed out. Gradually, the other junction is also brought into the anterior chamber and the intraocular lens is then extracted. Once the IOL was taken out, an area was observed where there was adhesion of the capsule, probably a pre-existing rent. No vitreous was noticed. Thorough wash of the anterior chamber was done. As the vitreous was not disturbed, and in order to prevent further rupture of the adhesion, a decision to implant a rigid PMMA was taken, which is implanted in the sulcus. Once it is in the sulcus, again AC wash is done and the wound is closed with a suture. First post-op follow-up, the eye is quiet, the lens is in place and the vision has improved. The final vision, however, was 660 most likely because of the pre-existing retinal schisis. Thank you.